Good afternoon, everyone. I am Dr. Sarah Mustafa from DentistChannel.Online. Welcome to today's webinar about medical emergencies in dentistry. While we are waiting for the participants to join the session, I will introduce you to our company. Dentist Channel Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first-hand information on technological advancements in the dental field. Now it's time to start the session about medical emergencies in dentistry. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Noor Al-Ain Abrar. Dr. Noor got her bachelor degree of dental surgery from Fatima Jinnah Dental College, Karachi. She worked as internee at Bahriya International Hospital and then as a house surgeon at Pakistan Institute of Medical Sciences, Islamabad. Welcome, Dr. Noor. It's our pleasure to have you with us.
Well, thank you for having me here, Dr. Sarah. So nice of you. I'm here, Dr. Noor, at Dentist Channel platform, and I will be sharing my lecture today with you all. And the topic is, as you all know, medical emergencies in dentistry. So shall we begin?
Yes, please, doctor.
Okay, I'll be sharing my screen. So is my screen shared, right?
Yes.
Okay. Okay. So here we begin like with the definition of the medical emergencies in dental office. What is a medical emergency in a dental office? A medical emergency in the dental office may be an unexpected event that can include accidental or willful bodily injury, central nervous system stimulation and depression, respiratory and circulatory disturbances, as well as allergic reactions that can happen at your practice. So there must be some precautions which we must be taking to avoid such injuries. Like some preventions, like there are steps dental teams can take to prevent emergencies from happening. Clinically, this includes obtaining a comprehensive medical history. Your medical history must be very nice. You should take history thoroughly, plus information about the current medications and the current medical condition and compliance, allergies, vital signs, and past medical history. There are a few protocols which are very must, and the dental practice should maintain all the protocols. Like they should maintain a written medical emergency protocol that outlines the expected plan for responses to medical emergencies and should be readily accessible to everyone in the practice and kept in a location where everyone can take that and see the history and everything, right? So to be effective, a plan must be a living document that is revised and improved regularly through the ongoing effort of the entire dental team. A successful plan will let everyone in the practice know the various roles and responsibilities that may be assigned. So there are few roles which are assigned to few different people. Number one, the number one person will be the team leader, definitely the dentist, the one who is doing the patient and managing the everything. Primary provides direct emergency care to the person involved in the medical emergency and make the decision whether to call 911. Always remember, when in doubt, make the call before waiting for anything else. Number two, the second person is the most available person, often the dental assistant who is nearby with you and who assists the team leader directly and is responsible for patient monitoring vital signs and application of oxygen. Person 3 is the next available person, such as a team member from an adjacent operatory who retrieves the emergency kit and supplies, prepares emergency drugs, and whatever else may be required. Person 4 is an administrative person, such as a dental receptionist who calls or who informs the ambulance if advised to do so, and who records vitals in or interventions and keep track of the time during drug administration. And they should be trained about such things and such medical emergencies happening at your if it happens at your practice. What are the products? All dental practices should have an equipment required to monitor vital signs, but the ability to obtain a person temperature, oxygen saturation, blood glucose readings cannot prove the beneficial during a medical emergency. All dental practices should have all the equipments, the first aid box, and all the requirements, and they should be trained enough to monitor the vital signs. Who are the people with you working, like your assistant and the receptionist. The ability to access and properly use such equipment should be considered when developing your practice's emergency kit, training routine, and when executing mock drills. Medical emergencies in dental practice may be loss of consciousness, respiratory distress, chest pain, cardiac dysarrhythmias, allergy sensation, stroke, blood pressure abnormalities, or emesis or respiration, and malignant hyperthermia. So, what is loss of consciousness? It includes syncope or hypoglycemia or cardiac arrest. We'll start from loss of consciousness, that is syncope, temperature drop in the amount of blood that flows to the brain. So, amount of blood flow cannot reach to your brain properly. With the amount comparatively to the amount it flows to the brain, and when you're like healthy, it doesn't flow to your brain well. So syncope can happen if you have a sudden drop in the blood pressure, a drop in heart rate, or change in the amount of blood in areas of your body. Prolonged syncope can lead to seizures. Hope you all are well aware of seizures. So, what are the causes of syncope? Vasovagal, panic, if you are getting some like stress, anxiety, hypoglycemia, heart diseases, some arrhythmias, blocks, or anything like heart attacks, seizures, diseases that interfere with CNS regulation of blood pressure, that is vasodepressor, and cardioinhibitory like diabetes mellitus and BP medications. So, what are signs and symptoms? In pre-syncope, nausea. The patient may feel nausea, sensation of warmth, lightheadedness, nephrosis, pallor, and tachycardia. And in syncopal state, that is the advanced stage, the patient will have hypotension, bradycardia, that is slow heartbeat, pupillary dilation, and so we'll treat the loss of consciousness accordingly, whatever the patient is feeling. In the early treatments, Tenderler that is, will give the Tenderler, and that is the patient is kept in the supine position. We'll see the excess level of consciousness. ABC, we'll check the ABCs and airway, breathing, and circulation. Will call the checklist will be medication, hypoglycemia, UVA, seizures, arrhythmias, anaphylaxis, and anxiety attacks. So we are going to tilt the head. 100% oxygen will be made sure to the patient. We'll monitor the blood pressure, pulse, respirations, ammonia capsule, cold compression to forehead and neck, and we will reassure the patient accordingly. So in advanced stages, that is loss of consciousness greater than 5 minutes or recovery, or maybe it may prolong to more than 20 minutes, we'll call the ambulance and will activate ACLS, that is ABC, and IV access will be given to the patient. In bradycardia, that is less than 60 beats per minute, in bradycardia, your heartbeat decreases. So the symptoms are altered mental status, chest pain, hypertension, SOB, seizures, and syncope. These are the what you will see or observe in the patient of bradycardia. So the prevention is in syncope, that sedation as needed, monitor carefully, give the supine position to the patient. 100% oxygen will be maintained for the patient in like as soon as possible. Identify the pre-syncopal stage, because identification is the must thing. As long as you're not identifying the what is happening with the patient, you cannot proceed with the treatment. You need to identify what the patient is. If the patient is having syncope or hypoglycemia or any heart disease, or there are symptoms to every disease. Then, okay, so here the summary for syncope is Trendelenburg, Bird, that is the supine position, airway must be given, that must be maintained there only, 100% oxygen is supplied, cold compress or ammonia, and excess loss of consciousness, and monitor vital signs. So next we have medical emergencies and loss of consciousness is hypoglycemia, which is very common in our practices. So what is hypoglycemia? It is reduction in blood glucose levels to below 50 milligram per deciliter, resulting in glucose deprivation of the CNS. The causes are excessive insulin or oral hypoglycemic therapy, missed or delayed meals, illness, infection, excessive exercise, or alcohol may be the cause. So in signs and symptoms, in mild signs of hypoglycemia, that is your sugar level is less than 60 to 65 milligram per deciliter, the patient will have cold, clammy, wet skin, extreme hunger. He will have extreme hunger. The patient will feel nauseatic, tachycardia, that is increase in heart rate, and numbness, tingling of fingers, and trembling. So what are the signs of symptoms of moderate hypoglycemia? That is sugar level falls below 50 of less than 50 milligram per deciliter. Extreme tiredness, irritability or anxiety, restlessness, fatigue, lethargy, headache, dizziness, slurred speech. The patient will not be able to say words easily. So, and in severe stages, that is your sugar level is dropping less than 10 milligram per deciliter, that there will be loss of consciousness, seizures, hypothermia, and coma. Loss of consciousness, that is hypoglycemia, in treatment is early is the patient is conscious. So if the patient is conscious, we'll stop the treatment. That is the first requirement of every medical emergency. Stop the treatment then and there. Give the supine position, maintain the airway, monitor all the vitals, check blood glucose level, and treat if less than 50 milligram per deciliter. So you'll give oral glucose. That can be, you should keep like sweeteners with you, and some like soft candies or something, which will increase your blood glucose level spontaneously. Regular soft drink, fruit juice, like juices with I always ask my patients to have mango juice because that's got a lot of sweeten in it. And treatment of advanced stages of hypoglycemia, patient becomes unconsciousness, and that is something to worry about. So we'll give the basic life support, right? Will activate the emergency medical service will with IV access, and 1 ampule glucose will be given, that is 50 milliliter of 50% solution. We'll check blood glucose like after intervals, like in intervals. IV infusion of 5% to 20% dextrose solution will be given. Without IV access, we'll give 1 milligram glucagon intramuscularly. We'll check the blood glucose level. We'll repeat glucagon as needed. So how is prevention taken for hypoglycemic patient? Will maintain the glycemic insulin control, or will avoid hyper or hypoglycemia, short appointments, early identification, early management. So that is, and we'll ask the patient already, for the patient who is appointed, to take all these precautions, to have breakfast. That is very important before, or to have something before coming to the appointment. So in preoperative type 1 diabetes mellitus, consider half dose of insulin if fasting. We're gonna measure the blood glucose on presentation. We'll give IV D5W, that is intravenous dextrose solution, that is mixture of dextrose and water. So we'll give it to the patient. In type 2 diabetes mellitus, we'll avoid oral hypoglycemic medication on the morning of surgery. So because we have, that is metformin, mostly patients are taking metformin, or it is modified with other medications, but the metformin is mostly what patients are taking in type 2 diabetes. And gliverides are also the ones which are taken by the patients. We'll check the blood glucose on presentation. So the summary is, stop the treatment as required in every medical emergency. We'll keep the supine position. We'll maintain the airway. We'll monitor the vitals. We'll check the blood glucose levels, and oral glucose will be given then and there spontaneously. Okay, so number third emergency in loss of consciousness is cardiac arrest. So we'll see ABCs of CPR, like check responsive, if no, because that's a severe life-threatening emergency, and you should be informing the authorities or responsible authorities who can take it seriously, who can do it better than you, because there are not a lot of equipments. You cannot do emergency ECGs and a lot of stuff at your practice. If no, then response, call 911. AED is actually a defibrillator. That is a device which checks if there is any disease happening in your heart, or that's a portable electric device, and which tells you about the heart rate and everything. We'll start CPR, and that is A for ABC, like airway. We'll open the airway with head tilt and chin lift. Will for breathing, will look, listen, feel for breathing. If not breathing, give 2 rescue breaths, because we have to start the CPR. And then circulation, check the pulse, look for other signs of circulation such as breathing, movement, and coughing. If no pulse begins, chest compressions. If there's no pulse, begin the chest compression between nipples. And chest compressions are different from, like, it depends if the patient is your young kid or the patient is an adult. So 30 compressions will be given at the rate of 100 beats per minute, and 30 to 2 compressions to ventilation ratio. So the new guidelines which tell us that the compressions are more important than ventilation. So what is ABC of CPR? When to shock? Like, we have to, if shock does not work, add pressure to the treatment, that is epinephrine 1 milligram is given, vasopressin 40 units one time is given. And when not to shock, pulseless electric activity, that is PA, will give the patient epinephrine, vasopressin, sodium bicarbonate, magnesium. This is a protocol which is given in hospitals for cardiac patients. ABCs of CPR continues. Okay, think of the causes. There are 5 H's: hypoxia, hypovolemia, hypothermia, that is shortness breath. Hypoxia is you're not breathing well, difficulty in breathlessness. Hypovolemia, hyperthermia, hyper or hypokalemia, that is increase or decrease in level of potassium. Hyperglycemia, your glucose is increasing. Hyperthermia, if your temperature increases. So, and there are 5 T's: toxins, tamponade, tension pneumothorax, and thrombosis and trauma. So what is the respiratory distress? That is laryngospasm, airway obstruction, dyspnea, and bronchospasm, asthma. So the definition is a protective reflex to prevent foreign matter from entering the larynx, trachea, or lungs. In larynx, what happens is that is a protective reflex which does not let the foreign particles to enter your larynx, trachea, or lungs. The causes can be foreign material in the region of vocal cord. Light general anesthesia will be given to the patient, which can cause laryngospasm. Or the signs and symptoms may include increased respiratory effort, crown sound in the partial laryngospasm, no air movement or sound complete. There is complete, if there is no air movement or no sound, there will be complete laryngospasm, and development of cardiac arrhythmia secondary to hypoxia, hypercarbia, and hyperkalemia. So respiratory distress, laryngospasm, the treatment will be in the early stages, rapid recognition and initial treatment of is essential. Pack of the surgical site, give 100% oxygen, immediate pharyngeal suction, and tilt the head as always, because head tilt is a must position to establish and maintain the airway. Pull tongue anterior, that is towel clip. You can do it with towel clip or something, and then observe or listen for air exchange. So the treatment in advanced stages for respiratory distress laryngospasm is complete spasm, positive pressure of 100% oxygen is given, and in continuing spasm, N-centine 10 to 20 milligram IU is given. So prepare for the intubation After entering, you must breathe for the patient until they recover, assist the ventilation until and repeat respiration returns as needed. Kids without IV give NC10, that is IM 3 to 4 milligram per kg or 1 milligram per kg sublingual. So how it is prevented? Throat pack is applied. The throat pack must be applied. Proper airway management should be done. Adequate suctioning must be done in between all the treatment and all of the treatment happening, and deepen the anesthesia with partial laryngospasm. The summary for the respiratory distress laryngospasm is that back of the surgical side, give 100% oxygen as required in every procedure, because most of the time there are foreign objects which will stop your oxygen level. So better to give the 100% oxygen, do the suction well, and tongue position is must to if you have to watch if the tongue position is right or not, and it should be kept interiorly. So the airway obstruction in the respiratory distress is obstruction caused by soft tissue in head and neck, bronchoconstriction, secretion, or solid causing a decrease or absence of ventilatory movement. The causes are supraglottic, tongue displaced posteriorly due to loss of tone of pharyngeal muscle secondary to anesthesia or sedation. So there are different causes. In supraglottic, tongue is displaced posteriorly due to loss of tone of pharyngeal muscles secondary to anesthesia, like anesthesia or sedation are the first causes, and then pharyngeal muscles tone, loss of tone of pharyngeal muscles is the other cause. Foreign body in larynx and pharynx, that is secretions or solids. Respiratory distress airway obstruction, that is what are the signs and symptoms are the patient might be choking, gagging, violent expiratory effort, substernal notch retraction, cyanosis, labored breathing, tachycardia followed by bradycardia, patient cannot breathe well, respiratory arrest, cardiac arrest. So the treatment in early stages is position upright, pack of surgical site, suction oropharynx, tongue traction, that is gauze, tongue forceps, and hemostatic suture. These all can help in tongue traction. In advanced stages, place patient supine, chin lift, jaw thrust, and then head tilt back and continue to try to open the airway. Check for sounds of respiration and ventilation if possible. Abdominal thrust if unable to ventilate. And treatment in advanced advanced stages is continued here, that obstruction or oropharyngeal airway, that is positive pressure ventilation must be applied. Treatment here for advanced stages continues, that is continued obstruction or endotracheal tube or laryngopharyngeal tube. These are given for the patient to maintain the airway. In treatment of airway obstruction of advanced stages, if the obstruction is still there, oxygen wire trachea catheter is given. Activate EMS, emergency medical service. And cricothyrotomy is the only option we have then. So we have signs of deterioration, that is cyanosis, loss of consciousness, cardiac or respiratory arrest, that was re-establish airway before addressing circulatory issue, re-evaluate the diagnosis, maintain basic life support. So what are the signs of recovery? That the patient is getting back to the life, that is normal breathing returns, foreign body is removed or swallowed. So solid objects are cuff to attempt to remove. When the patient swallows any object, then the patient should cuff, or you should ask the patient to cuff and to attempt to remove the foreign object. Sit upright. Oh, sorry. Sorry for the inconvenience. So in solid objects, cuff to attempt to remove it, and sit upright fast, and cuffing if unconscious, and complete airway obstruction. That is Henley in adult and kids that is given for greater than 1 year old. And if partial obstruction is there, then Henley is not recommended, and the cuffing should be asked by the patient to cuffing should be encouraged here. You have to stand behind the patient, place a fist of one hand slightly above navel, grasp quick a fist with the other hand, quickly upward thrust to the abdomen, a chest thrust in pregnant woman, and continue until object is expelled or loss of consciousness occurs. An inhaled object, not cuffed out. So X-ray. So then we see it on the X-ray of the chest and upper GI, and all pulmonary objects must be removed. So the prevention is that proper throat pack should be kept, removal of dentures, in proper throat pack, or you should remove the denture, partial dentures, adequate suctioning must be done, adequate visualization of the surgical feet, maintain the held position, use rubber dam while doing endodontics, and choking and loses consciousness called 911, lower patient to ground, place patient on their back, tongue jaw lift and finger sweep, open airway and attempt ventilation. If obstructed, reposition and try again. If there is the foreign object is still present, then reposition and try again. If obstruction persists, give 5 abdominal thrusts using the heel of one hand above the navel. Repeat until obstruction is relieved, and consider surgical airway. So the summary here is upright the position, pack of surgical site, suction it well, determine if obstruction is needed, indeed occurring, and Hamlish maneuver is also required. So in dyspnea, the definition for dyspnea is that sensation of labor, difficult and uncomfortable breathing. It occurs when there is inadequate control of respiration, oxygenation, and ventilation. The causes are heart diseases, the COPD, one of the main cause, which is like the diseases of the lung happen in it, like asthma, emphysema, chronic bronchitis, or anxiety or hyperventilation, aspiration, lung infection, pulmonary embolism. These all can cause dyspnea. In signs and symptoms of moderate dyspnea, in moderate, there is not enough air sensation, shallow, slightly labored breathing, SOB on mild exertion, and cannot complete sentences due to breathlessness. In severe stages, the patient will have chest tightness, severe wheezing, such sounds, anxiety, fear, agitation, and restlessness, also drowsiness. In treatment, airway is maintained first of all, assist the ventilation as necessary, 100% oxygen is given, monitor the vitals, pulse oximeter, end tidal carbon dioxide, BP, and transport or call emergency medical service if unstable. That was it for the basic medical emergencies and how you must attend them and how you must treat them. Over to Dr. Sara.
Thank you so much, Dr. Noor, for this informative session. So meanwhile, I'll ask your permission to introduce our company to all the participants, and I request all the participants to kindly put their questions in the question and answer box.
Yes, sure, Dr. Sara. Go ahead.
So this is our organization, DentistChannel.Online, Healthy Smiles, Wealthy Lives. DentistChannel.Online is India's first digital dental media company. We did webinars and workshops with more than 400 national and international speakers, many successful world implant expos, and much more. If you're not a Prime member yet, kindly join our family to get free certificate of participation after every event, and Prime members will be awarded with 1 CPD CE point for each webinar. To become a Prime member, you can use the link, it is in the chat box, and you can use my code SAR100 in order to benefit from a discount. This is an example of the certificate of participation that you will get after every event. About our upcoming webinars, we have a webinar tomorrow at 7 p.m. Indian Standard Time with Dr. Wael Hayyan, Indirect Veneers from A to Z. We have another webinar with Dr. Alessio Zanza from Italy about NITI instrumentation of root canal systems, the endodontic challenge. On March 20, we have another session with Dr. Vishal, the eyes see what the mind knows, understanding oral precancerous lesions. Also on March 20, we have another session with Dr. Ankush about pain. Let's crack the enigma. About our online master classes, we have one with Dr. Jaina, Communication, the Key to a Successful Dental Practice, happening on March 26 from 10 a.m. until 1 p.m. Indian Standard Time. About our upcoming workshops, we have an on-site workshop happening in Classical Hall, Suwaida, Syria, with Dr. Salam Harfoush and Dr. Aya Abu Fakhr about basics of dental veneers and dental photography. You will have a certificate by DentistChannel.Online with 12 CPD accredited by State Dental Association, Germany. I request all the participants to kindly save this number and then send a message on WhatsApp with their name, so they will be added to our broadcast list and they will receive everything about our upcoming dental webinars and courses. Today's webinar is sponsored by NovaMind. NovaMind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implants types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. Dental implants and dental restorative solutions produced maintaining all the standards of EU medical device regulatory. Products are manufactured in Athens, Greece, and distributed worldwide with more than 1 million happy restorations. If you want to know more about NovaMind, kindly check their website. Last but not least, don't forget to follow us on our social media platforms, Facebook, Instagram, and YouTube. So now it's time to move on to the question and answer session. So, doctor, it seems that all was fine, all was clear. We don't have any question. We have good feedbacks, very well explained, and a very nice presentation. I'd like to thank you again, Dr. Noor, for sharing your knowledge and experience with us.
Thank you, Sarah, for having me. Thank you for the invitation.
It was a pleasure having you with us. We are looking forward to organizing more webinars with you in the future, inshallah.
Inshallah.
Thank you, everyone, for joining us today. Have a nice day, everyone. Bye. Thank you.
You're welcome.